Okay. Good morning, everyone. Welcome to PerfWeb 75 Day 3. Thank you for joining us. Today, I'm Tammy Sparacino, your guest host, while Joe Basha is out of the studio. He will not be joining us today, but we will be joined by one of our favorite panelists, Matt Warhoover. He's coming to us live from Nashville, representing Vanderbilt University Medical Center. Good morning, Matt. How are you?
Morning, Tammy. How are you?
I'm good. Thank you so much. I appreciate you joining us. I understand you've been quite busy over there. Had some busy nights working this week, huh?
Yes, we have. We've been a little bit on of a roll this year. I think yesterday we did our 22nd and 23rd heart transplant of the year. So
Oh my
it's
goodness.
and I think we've done 11 this month already. So it's been quite a busy month.
Wow. Well, that's wonderful. I mean, you guys just rolling out from last year into the new year and doing great with that. Well, that's just such great news. Well, we thank you again for joining us. We know that you have been getting very little sleep, and we are glad to have you here. So, what are you going to be talking about today?
Um, you know, I think we're a little over 2 years into this COVID pandemic, and really, I think from the centers that I've spoken with, just locally in Nashville, and then regionally, some of our ECMO centers, people are starting to change their patterns on not only who they accept but how they staff it, and what some of the boundaries are that they're willing to do. And so I'm really going to review what we've done at Vanderbilt for the last two years, and how we've changed as far as our overall scope of dealing with the COVID pandemic, and the people that are referred to us, both externally and the patients that we get internally, and just a lot of the management and decision making on who to treat, how to treat, and what methods that we go about making those decisions.
Okay, well, that sounds very interesting. I'm sure that's going to be really very useful information for a lot of our viewers. Well, I'll go ahead and turn the floor over to you, and we will let you get started with that.
Sounds good. So Joe asked me to really take a deeper dive into looking, what have we done as far as resource utilization. And I know this is a perfusion forum, but this will be a broad scope of, from a 30,000 foot view of just the whole hospital, mentality of how we've had to change our strategy, and how we've evolved over the last 24 months with this pandemic. So we'll just jump right in. Next slide. So I really wanted to start out with a timeline. So we put our first COVID patient on back in May of 2020, and these are fiscal years that I've got up there. So we put 5 patients on within the first probably 60 days of 2020, between May 2nd and June 30th. And then the next fiscal year, we put 42 on, and year to date, we have 34 on for this fiscal year. So as you can see, we were a little bit hesitant to start putting these patients on. I believe the pandemic officially started sometime between January and March, depending on where you were in the country. We really didn't see. We were prepared for it as a medical center, but we really didn't see our population really light up with the COVID-19 disease process until probably after spring break of 2020, April-ish. And then, that's when it started to kind of peak the first time in Nashville, and more importantly, I guess, to the region of Middle Tennessee. But as you can see, it's not stopping. We're pretty consistent. If not, I think we will be over probably 42 cases when it comes to fiscal year for this next fiscal year. So I think we'll probably overtake that number by July 1st. Next slide. And so the very first thing, this is what we decided to do. This was our first iteration of more or less classifying who we would put on ECMO and who we would not. And this was if you want to say, this was our first trial at this. And there was, I can tell you there's many iterations that we've gone through, but it was more or less of a living document, and it was kind of a fluid document. But we did make a hard stand twice, and we just said we need to get this. We not only get it right, but we need to refocus and really get these things down. So this was our first attempt to do this. We first started off with saying that there are some absolute contraindications, and then there were some relative contraindications based on multiple factors. If they were if the patient was prolonged exposure to to Optiflow or BiPAP, more so than what we would like to see, but they were perfectly healthy and they fit all the other criteria. Just because you were an outlier in one of the relative contraindications didn't mean that we didn't accept you. But as you can see, we put a hard line on 60 years old as an absolute contraindication, but we did consider people a little bit older than that if they were really active, great shape, no comorbidities. We did do a BMI the same way. We tried to restrict it to less than 45, but we did go up to 52 or 53 in some cases. The mechanical ventilation was 7 days. We did go up to 10 days in the first cohort of patients. Of course, we wouldn't treat anybody that had irreversible neurologic injury. And then if we had some chronic respiratory issues, we didn't really find them as candidates for ECMO as well, because your baseline of your respiratory status was already in jeopardy. And so those were pretty solid, and we stuck with those throughout. The relative contraindications, the ICU days. In the beginning, we were pretty stiff on that, on not wanting to accept. But as patients, became, I would say, sicker, and hospitals started to fill up, we kind of knew that we had to extend some of these other criteria on what we were doing. So next slide. And so once we sorted them out, who we would accept and who we would not accept for ECMO candidates based on the contraindications, we kind of stratified those patients on, should we put these patients on ECMO, or should we actually try to treat them in a non-ECMO cohort and see if they progressed, with conventional therapy or even some non-conventional therapy. Would it be proning or maximizing ventilator settings? And once again, as we gleaned more of this information throughout the process of the couple months to a year that we did this initial settings, we found out that actually putting people on max ventilator settings was actually more harmful. They were not your typical ARDS patients. So putting them on max ventilation prior to putting patients on ECMO, it actually, we found out that it hurt our outcomes, if you will. Mm-hmm. So we were a little bit more inclined to pull the trigger, and we'll get into that more so, but we would pull the trigger on putting them on ECMO more readily earlier in the disease process, until instead of letting them progress further and further down this Stratus, and then finally say, well, we don't have any other therapy. We've tried everything. So this was a learning curve. So I guess next slide. And then if we also had to think about our resources as far as from as a leader in Middle Tennessee. So mechanical ventilation, we were getting a lot of calls, and so patients that were on 8, 10, 12 days on outside hospitals, it took us a while to get that more or less idea out that please call us earlier in the mechanical ventilation days. And we would, even if we didn't have a bed at the time, we could talk some of the outside hospitals into some of those scenarios that was on the previous slide about proning patients, doing some alternative ventilation strategies to try to manage them from afar. And then for the patients that would not respond to those, that then we could bring them in as a transfer. But we were really at some points throughout that first year, we just didn't have any beds, and we were trying to manage from afar some of the patients in other hospitals, and as a collaborative effort, putting some of the docs and the hospitalists in the outside hospital community with our internal team, and we were doing conference calls, almost on a weekly basis, touching base with and reviewing all their patients that they had, and the ones that they were concerned about that they weren't going to be able to take care of, and that they really needed ECMO. And so it was almost a week-to-week consult with some of our more close partners in Middle Tennessee. Next slide. And then, so we, over the year to, I would say 15 months, we developed some things that we learned, and we said that, the BMI of 52, that wasn't going to work. Really, BMI of 50, we kept pushing that number 45. Well, this one's 46, 45. This person's age is 61. And really, we found out that, there were some hard, fast numbers that really, from a utilization of resources standpoint, we just we felt like we weren't doing ourselves a service, and we weren't doing the community a service, because, as you know, if you say yes to someone,
Yes.
you're absolutely having to say no to someone else.
Yes.
And that's actually where it was. And it is a tough decision to make. I don't ultimately make those decisions, of course, but I'm in on some of the calls, and I can hear it. And those are tough calls to take, that you say, we are not going to be able to take this person because we feel that, for X, Y, and Z, they're too far into the disease process, or they've got other morbidities and comorbidities, and we have to be able to, set a line to work, because resources aren't endless, and whether it be pumps, whether it be nursing staff, whether it be NPs, and just sometimes it was disposables at some point, that it was not an unlimited supply of resources. And so on the 19th of October this last year, we set some new standards that we revised over the learning of what was working and what wasn't working over the 15 months. Next slide. And so we came up with this priority scoring system for the COVID patients. And it really had to do with two, I guess, criteria. It had patient information that was a part of the scoring. And then we had our own hospital information on where we were as an institution, as far as where our resources were. But we actually put it into a more or less a stratified ECMO score, and we just did a point system to lower the points. It was a better. We felt it was a better candidate for our utilization, and this is. I'm just gonna, before I go through, I don't need to go through all this. We'll touch some highlights, but this was well thought out, and in my mind, there was a lot of collaboration and a lot of discussion around all these point value. It wasn't just arbitrary. We looked, retrospectively at some of our data that we had and some of our patients and some of the success stories, and then unfortunately some of our, not so successful cases. And we kind of said, well, why do you think this wasn't a success? And we gave a point value to some things that, that you say, well, that person should have done okay. And with the, things like acute kidney, if you're receiving CRRT already, that you already have one organ system that's really already down, and providing a second organ system support like ECMO, it really, you're spiraling down already. And so we really looked at some of these things and made a hard cutoff, on some contraindications, but we really weighed heavily on some of the comorbidities that we just said, they add up, and we know where this is going to go because we've seen it before. And if you don't change your strategy, that's the definition of insanity. If you do the same thing, right, thinking that you're going to get a different outcome without changing things, you're just not setting yourself up for success. Mm-hmm. So we put a hard no on anybody over 50. We put a hard no on anybody over a BMI of 50. We put a hard no on if you've been intubated more than 7 days. I'm trying to recall all the things that we did say. If you were anuric, definitely that was a no. So we went and put these scores together, and this was, like I said, based on only the patient criteria. And so we trimmed that and kind of brought in our margins a little bit on who we thought the therapy was best suited for, and then put it in a score. And anybody with a green in that score, this was phase 1 of yes, we would do it. And then we would go to the second phase, which we're getting ready to talk about. And that's where you had to have 2 check boxes. One, the patient was right for ECMO, but 2, was the hospital ready for adding 1 more patient. In the yellow, there was a discussion between there was a discussion of 3 different physicians based on who was on call that weekend or week, and they would have a 3-person con call discussing anybody that was in the yellow, and then anybody that was in the red, it was an absolute no. There was no conversation about that. So next slide. And then this was the, I'm sorry, one more. And then this is the health system information. So this was the part 2. So when we would get a call from the outside hospital, the very first thing that our house supervisor said, this was more or less the litmus test. Was it appropriate for Vanderbilt to be getting that phone call? Are we the right center to be getting that call? Have they called a closer ECMO center geographically where the call was coming from? Because resources were thin, beds were thin, and so you don't really want to say this, but you have an obligation to really take care of your community surrounding you. And right, there's a radius that goes around out of Nashville, that goes into Middle Tennessee, that goes into Kentucky, that goes into northern Alabama, northwestern Georgia. So those areas we say those are the people that we treat every day. Those are the phone calls we should be getting for these patients. And so if we got a call from Kansas, or we got a call from Western Arkansas, why are we getting that phone call now? And time again, it was that they had called the nearest ECMO center and they were full, or they called that nearest ECMO center and they were denied. And so when we were getting the phone call, it wasn't usually that it was an inappropriate call. It was that the other centers were doing their due diligence. They were calling the next closest center that that didn't say no. And so I would say a majority of the times, it wasn't, it was the right phone call for us. Now, whether we could take that patient or not was different every time, but it wasn't that people were just trying to skip centers. Things, a lot of the times when we were getting these phone calls from centers that we don't typically get calls from, it was because the centers nearest them were absolutely full. And that was the geographic limit. And then, the equipment limit, for outside, was there a cardio help or a centromag available? And would we allow to, if we put that next patient on, did we have at least one backup of that particular type of circuit? At the time, prior to October 19th, we had 3 different types of systems that we were using. We had the Soren, we had the cardio help, and we had the centromags. In the end of October, we added the Spectrum pumps to our fleet, and that was really when we said, okay, we need to really, retool this this decision-making tree. We have more pumps now, but that doesn't mean that the floodgates should be open. And that was really buying more equipment. It was really really a hard, fast, more or less point in our progression of why we had to come up with this, because we did have 7 more pieces of equipment that we could put people on, but that doesn't mean that all the phone calls you should say yes to now. And so we really wanted to drill down and retool this. And so equipment was part of that discussion, and then most importantly, personnel was not only from the bedside nurses, but from our NP and our APP staff. We put some thresholds on what we were willing to do as far as ratios and how thin we were, and just the overall number of patients that we would have in our units, because as ICUs get more and more acutely ill and then chronically ill for these long-term ECMO patients, it can be demoralizing, especially if if you don't get a win from time to time on a really good story. It seems like a lot of people remember the horror stories or the things that the patients that really affected us emotionally, that really didn't have the outcomes that we would of course like to see. And people can get a little bit depressed. You see it, and you just have to be able to have some wins and focus on some of the wins. And so we just said that we were not going to take more than 6 across 2 of these units, and that's kind of, it was not only from a personnel, from a numbers, but just a mental and morale type atmosphere as well. If we go back to the previous slide, I apologize. Wanted to get back to that. For the inclusion, the second part of the patient information, like I said, there was 2 check boxes. One, the patient information had to be checked, and then the hospital system had to have a check for us to accept that patient. The one thing I did want to point out on this is that the top section in that phase 2, the ECMO inclusion criteria. So every single member every single patient that would get referred to us, they would actually get a patient advocate. It was whether it be one of our ICU physicians, whether it be one of our NPs. They took the phone call from our call center, and they got all the information, and they were the direct contact. And so we had one person gather all that information, and then they would present it as kind of, and they would be, they would present it as it was almost like a case in a case conference, and all that information, they were the point person from our hospital to that hospital, and so there wasn't any information that was misunderstood. It was very important that we got all that information from one source, because some of these, as you get some of these travel, transports, what you get in the report, it's like the telephone game. You hear bits and pieces of it, and by the time you get there, it's a completely different picture. And so that I wanted to point out that that's really important. I think that when you go to accept one of these patients, that you have the same person taking care of all the information and being the spokesperson, and it's one voice, and it's the information comes from one person.
Yeah.
And so that I wanted to point that out, that was one of the most important things that we actually came up with, that said we're not going to have multiple people on point
Right.
working on transfers. It's one person works on one patient on the transfer. So we can go through the next couple slides. And then finally, we did this priority scoring system. This was I think we took this. We used Minnesota's and Charleston comorbidity index. That's what it was.
Okay.
And so this is the point system that we used. And it's more of a drilled down, and there's some links to it and people were a little more, let's just put it, it was a little more black and white. You took feelings as much as you could take feelings out of the decision, because a lot of life flight transports, they do the same thing, is they don't want to know the background information on what happened to the patient, because it can mentally affect your decision making, especially when it comes to transporting patients, and that's kind of where mistakes can be made. So this more or less took the feelings out of the decision making of who we were going to put on and not put on, because it's tough to hear some of the background stories that people that have 4 kids under the age of 18. Those things can weigh in on a decision. But we really I think that was the other reason why we had one person get the information, and that person just presented the case. They just presented facts, and they didn't delve into should we take this person or not. They were just there as the spokesperson giving facts. And so you can see that the Charleston comorbidity, we did the Minnesota scoring system. There was multiple different scoring systems, but emphatically, we ended up with this. And this was kind of our go-to. This is what we currently use right now. And we go through all these scores, and at any given time, if it's in the red, the process is stopped, and we go, we don't need to move any further. So I think that's one more slide. And this is kind of the scoring system based on that Charleston of these are what we go by as far as the scores 1, 2, 3, or 4 about platelet count, liver function, where our cardiovascular status is, your renal status, and of course the Glasgow coma score. We put all this stuff together, and that you get a what I want to call a unbiased. It's black and white. It's a hard number, and it's actually a score, and so it doesn't take into personal feelings or any other outside source. And really, it's almost like rationing, but at the time that's where we were at some of the peaks of COVID.
Right.
And so this was really, I just wanted to lay the groundwork about where we started and kind of how we progressed. And it started off that it was usually a small committee, and we would get a phone call. We said, yeah, we could do that. At the beginning, hospital wasn't so full, and eventually it was kind of, well, we did that for that patient, and this patient seems like they're healthier. Why don't we do it for this patient? And with that kind of mentality, when you're looking back, and it's it's really arbitrary, and it's based on feelings and opinion. That's when you kind of can get in the weeds, and then you can even a little bit of infighting between physicians to say, well, why are we going to do this again, or this patient seems healthier. And at that's the wrong time to actually have a little bit of disagreement, even on the front end of seeing who gets patient resources. So that's what I've got. But I think this is more of a discussion than it really is a than a lecture. So I'd
Right.
like to open up and have some discussion about it.
Well, thank you, Matt. That was very informative. I think that just seeing your progression, you're at such a big institution, you've seen a lot, probably some of the worst that anybody's seen as far as numbers of patients that you had to treat during this whole period. And seeing the evolution of kind of where you started, which was, I think, like a lot of places that were already doing ECMO, right? You were taking these patients, doing the best you could, sort of seeing how this was all going to play out, because we weren't really sure how effective ECMO was going to be, when we should do it. You know, do we wait until it's the last ditch effort? Do we do it earlier? But then if we do it earlier, are we putting patients on that we could have kept resources available for a sicker patient that might have come in? You know, we just didn't know. But ending up with this scoring system, I think, is really impressive. It makes a lot of sense to me. All the things you were saying, you probably couldn't see, but I was nodding my head because it's what we saw as well. You know, we would put a patient on, and it kind of depended on, you know, we work at multiple facilities, which means we also have multiple hospitalists and intensivists that are often making these decisions. And although I'm sure each of them were making sound decisions based on their decision processes, it was different. So we might be at one facility, and depending on whose week it was at that facility would depend on the kind of patients that got put on ECMO. And then, but that's, you know, with these runs lasting so long, that's a lasting effect. You know, that could be a 4 to 6 to, 3 months decision that one person made, even after, some of our surgeons were, starting to try to find some guidelines. And because we were running out of resources, and it would be, we're not going to do patients, for example, with BMIs over this amount. But then you got someone who, it was their rotation week at the hospital, that's the intensivist, and they really want this patient. So they're advocating because that was maybe their patient, or they got involved early, with the transfer, and it really showed a lot of differing criteria that was being used. Whether or not we were accepting transfers, same thing. Houston's a big city, so we serve a lot of people and the surrounding areas, but we got calls for transfers all the time, and our group wasn't really involved in whether or not a patient got accepted, but some of these patients would be coming just to our centers because perhaps ECMO wasn't available at their center, and they would come, and they were specifically transferred for ECMO, and then we got them, and they either didn't really need ECMO, or they were not a good ECMO candidate. But now we have that patient, and we own that patient, and that patient's now taking up another bed, that we really need for what's in our immediate community. So I think we saw a lot of the same struggles on a much smaller scale, but we never evolved into a really sophisticated way to determine the best way to utilize the resources that we had. And I still think that it's sort of gotten quiet here in Houston for us with the COVID ECMOs. But if it were to have another surge, we're no better off than we were in the beginning, because some of those hard stops we did anyway, and a couple of them might have had a success story, if you will. They came off ECMO and they made it out of the ICU, and so then that really makes it hard to say, well, was that a good hard stop or not? Or was that person just a really lucky outlier, And without any way to really justify who you're picking, it seems like really unfair rationing. So I really like the term that you used for that. We do have to protect our resources, but we need to find a way to do it so that it is as fair as possible. Because I like something that you said. I wrote it down. What was it? Yes to someone means no to someone else. I mean, we saw that quite a few times. You know, we actually got a good candidate come in, but we didn't have any more machines, or we didn't have any more nurses, or it wasn't even an ICU bed, you know. So a patient that might have been a really good candidate is now waiting somewhere else for a current patient to either get better or die, you know. And all the while, that good candidate's getting worse, you know.
Right, and that's actually, you're exactly right. That exact example is the reason that we actually said, as a group, we have to go to a scoring scale.
Yeah.
Because at some point you have used your last bed, you have used your last machine that doesn't have a backup, and I don't know if it was Murphy's Law or whatever it was, but as soon as we got to that point, we would get a phone call for someone that was, really ideal, a very young patient, no comorbidities, single organ dysfunction. And you look around and you go, we don't have another machine. Right. We don't have another bed. And to the point that, like I said, I didn't come up with that, but that was kind of the universal, if you will, mission statement internally, that when you say yes to the very last person you can say to, you've used your last resource, you will say no to the next person. And you said no to someone. So when you do say yes, to someone, you say no to the next. And that's really what caused us to do this, is because we were time and time again, we were going, this patient that we just got the phone call really needs our help and is a great candidate, and we just didn't have the resources to do it. So we had to ration it.
Right. We even had something that, hit really close to home at one of our hospitals. We were at max capacity. We were I think it was around surge 2. We had already gotten, as many extra machines that we could, and people were still highly motivated then. It was starting to get wear on people, the lack of successes and the long runs, and the nurses, having to manage so many patients at a time. But people were still, very hopeful that we were really doing some good. And we got a phone call of a patient, of one of our own, if you will. So, it was an immediate family of someone who actually worked in the ICU, and it was a good candidate. And we didn't have any resources to help someone that was actually in our very close-knit, community, because we had already utilized them all, and they weren't really all great candidates, right? A couple of them at the time, it was one of those that the patients were in crisis, and even though they were well past the ventilation or time, or they were, really high BMIs, already in renal failure, but the emotional factor played in, and they got put on ECMO, and now, although they are not dying actively, they were languishing and not improving, and you're stuck then, Yep. So we really started trying to push for some kind of way to have a look at these patients from a more objective perspective. I think that something else you said about having a single patient advocate assigned to them, I think that's a really great idea, because you're right. We've got so many transfers in that we don't typically go pick up the transfers. That's more rare for us. We just receive them. But so many times we get the information from the intensivist, who then got the information from whoever called them from the other facility, and then you get that patient in, and by the time everybody gets together, no one has the same story, and usually what's actually going on with this patient and what their actual criteria is, it's completely different. You have just bits and pieces, and so it can be difficult to make those decisions, especially when it's in a more urgent type fashion. That the patient's not doing well, they're at a place that's not an ECMO center, we're putting them in an ambulance and they're coming to you right now. We get the call, we're primed, we're ready to go, and the patient gets there and maybe they don't need ECMO at all. Maybe they needed some additional ventilation strategies, and maybe we're able to stabilize them, So we saw a lot of that. I do have some questions, people chatting with us on YouTube. So let me just look at some of these questions. So from one of our viewers, Madima Rose, let's say, they said, I think you've answered this before, but honestly, I can't remember the answer. So how many ECMO beds did you have or do you have available? What's the amount that you reserved to be able to do ECMO?
So we didn't reserve beds. What we did was we had a total number of machines. So we had prior to mid of October, we had 13 machines.
Okay.
We had 15 machine, or we had 16 machines, and we could do 13 ECMO patients because we had 3 different systems and we needed a backup system for each one of those. So we had 16 machines, but we could only put 13 people on, and that was across 3 different units.
Yeah.
We put people on in the CD ICU. We put people on in the medical ICU, and then we had a medical COVID ICU. But remember, those are 13 ECMO patients. That's just not 13 COVID patients. So, that encompasses, we were the biggest heart transplant center in the world. So when you're doing heart transplants, that volume, it doesn't always work out. And so you have to have, you have to have backup on that. So we would only go down to if we had 11 patients on, we wouldn't accept any more because we needed 2 more circuits for our transplant patients, and so we kind of held a hard number at 11 until we got those 7 more machines.
Okay.
And so at that point, it opened up some more capacity as far as equipment. But in the beginning, it was equipment. Now it's more hospital and personnel, if you will.
Gotcha.
And that's why that second phase came in, because we knew that we would have the equipment, but once again, is that the right thing to do as far as from a morale standpoint? Because once again, like you said, once you put them on, you're committed.
You are committed.
And you can have nursing staff available for days 1, 2, and 3, but you look later on in the week and you go, we're not going to have enough nurses that are trained or qualified, to sit with these patients. So we had to look at the personnel standpoint.
Absolutely. You bring up a good point, and about reserving. You're still running a heart program. You're running a transplant, but even in our community hospitals, we were still, doing hearts. We had a few times that, there weren't beds available, and so we kind of went quiet for a week or 2, but then they would ramp right back up as soon as we had a few beds available, and we were having to, keep having that discussion. We need to reserve, a machine, at least one machine, so that we have an exit strategy if we get into trouble. At one point, one of our busier facilities, we had, I believe it was 6 on ECMO, and they were all COVID. And we had used our last ECMO machine at that facility. 6 was our max, but we had an extra heart-lung machines, and so we had said, well, that's our backup, I guess, because our heart-lung machines run the same kind of centrifugal pump for our ECMO. And then we got a patient that was not COVID and could not come off bypass, and we had to convert to ECMO using one of the heart-lung machines, and then we're down to a heart-lung machine. So, you really do have to draw a hard line, because now we only had, a machine for heart surgery with nothing, as a backup, not even another bypass pump, So I do think that you have to look at, although it can be difficult, it's emotional, we're talking about people's lives, but we also have to talk about, think about rather, protecting the patients that are going to come through that we haven't seen yet, Another question from Madima is, how were your ECMO outcomes varied by the different variants? Do you have any either anecdotal or data available on that?
Yeah, so we just reviewed our data. So are you talking? I guess I don't understand the question, other than, are you talking about when it comes to our outcomes per device of our 3 systems? We don't see any differences in that, but as far as before and after, like when we made the hard stop.
I think that what they were asking is, whether it was the initial variant, or Delta, or Omicron, or whatever. Right. Did you see different outcomes based on the variant of COVID?
I will say that I don't think that we haven't stratified that data yet. Mm-hmm. But if I would just anecdotally say, we are getting better results. So we were closer to 50% survival. We're up to 65% survival now. So as we've talked about, we broke it into quarters, and then we got an overall number. So in the beginning, we weren't as successful as we are now. But I think it has to do with that our selection criteria has gotten a little bit trimmed in, but also the ventilation strategy. I think I pointed that out. We were trying to push people and say that we'll try to do more aggressive ventilation strategy before we put them on ECMO. And it seemed as though that the lungs were being beat up prior to going on COVID or going on ECMO. And so we pulled the trigger earlier on patients, but we also, tightened up our criteria. And so, of course, I think that provided, whether you want to say artificial, but our numbers have gotten better. And so I would say it's probably due to those 2 factors. We're putting more people on early, and we're actually being a little more tight with our selection criteria.
Well, that makes perfect sense. And we kind of had the reverse, and not because we've changed our criteria, really. I mean, there was a little bit of relaxing of the criteria, I guess you could say, after the first surge, simply because we actually were pretty successful in our community hospitals with the first surge. We were quicker to put people on, and so we had, somewhere around 50% survive and come off ECMO, and then that sort of, everything kind of died down. We thought that was the end of it, and then the second surge came, and so people were quick to want to put these patients on ECMO, and we put maybe some larger patients, maybe people that had been on ventilation longer, and then that didn't go so well. Our success rates dropped. And then in the third surge, we found that they were delaying putting on ECMO, because now they're doing kind of what you did in the beginning, where you were trying to do these other things. Is there anything else that we can do? And waiting too long to put them on ECMO. So really, I think having the criteria, we have a longer period of time. So we're hoping that at our facilities that they're really going to start looking at, well, what worked here and what didn't work, and maybe come up with something. I'm sure it won't be as sophisticated as what you came up with, but maybe it'll be similar. And we're hoping that when something like this happens again, we'll have a little bit better knowledge on how to really manage all of this and do just the very best we can. So thank you for those questions. I think they were great. Well, Matt, what's going on as far as your COVID ECMOs? Just an update for everyone since we're kind of talking about it. Are y'all still staying pretty full with those over there?
It seems like we were down to 2, and then all of a sudden we'll bump up to 6 or 7. I think we're down to 2 again. Mm-hmm. It just seems as though we get these waves of peaks and troughs. I don't think it's I don't think it's ever going to go away. Eventually I think it will, but it just seems like it's been a very long time. Just when you thought we were, we may get down to 1 or 0 of COVID patients, you see a couple more trickle in, and then a couple more lead to 6 or 7 again. And I think it's just the cyclic of the holidays.
Yes.
We, as more people, interact, I think, that's what happens. But that's where we're at now.
We're in a valley right now, and we're have 0 patients. I hate to even say that out loud because we've gotten so close to that so many times, and then the exact same thing would happen to us. We would have a peak, and we would start seeing those patients again. I'm interested to see what's going to happen now that I've been reading that a lot of places are relaxing their mask requirements, and so now that we're kind of out of the holidays and we're coming out of winter, and that's typically when all of our flus and things like that really peak. I wonder what's going to happen now that the mask mandates are being relaxed some, and if that's going to affect us, or maybe we're just kind of finding a new normal where we're going to have them around, but maybe not in an overwhelming number. What are you seeing there?
I would agree. I think it's just going to be it's the new norm. I think we will always, like I said, I hate to use the word always, but I don't think that I think we will continue to see 1 or 2 come in from time to time, and like I said, I think around bigger gatherings, and I think it's just gonna you'll get these spikes in it, but I just don't know when or where it ends. But I'm hopeful that one of these seasons that all of a sudden it just goes away, and it's something that we look back on and go, well, what did we learn from it? And we'll be having discussions like this about what did we learn from that experience, and that we can do better in the future.
Absolutely. Well, thank you so much. I know you probably would like to catch up on some sleep, or you're probably due at work, but we really appreciate.
I'm due at work.
You're due at work. Well, we really appreciate you taking the time to share all of this with us. I know our viewers really look forward to the monthly check-in from Vanderbilt, so we thank you, and we hope everyone has a wonderful day. And Matt, why don't you close us out?
Okay. Well, Tammy, thanks again for having me on. The Vanderbilt faculty really enjoyed this monthly discussion, and hopefully we'll see Joe next month.
Yeah, absolutely. All right, everyone. We do have another program tomorrow at 3 o'clock Central Time, and we will have Joe Basha back in the studio, and we will have our monthly guest, John Ingram, with his knowledge nuggets on septic shock. Thanks for joining us. Have a great day.
Thanks, Tammy.